Hi, I'm Kathy Thornhill, founder of Chat and Chew, and you're joining us at Chat and Chew Live, online. What's Chat and Chew? Well, it's a health study group of people who've come together because they're interested in taking care of their own health through some dietary changes. And we do that in a variety of ways. We provide information, we have demonstrations, we have speakers, both live and through Skypes. We also have meals together, we do tours together, we have friendship together to help each other as we meet our own personal goals. All of our meetings are based on the research and clinicians who have worked hard to determine what's the connection between diet and disease, the chronic diseases that Americans often get. And so one of those experts, Dr. John McDougall, he speaks to us about the importance of beginning the right way, and that is that if you are filling your plates with lots and lots of plants and lots of starches, you'll want to add a B12 supplement to your diet. Also, he suggests that if you are sick, if you're on medication, you check with your medical provider first, because diet is powerful medicine. And that's something you might want to do, is be sure they're in the loop and they know what you're doing. It doesn't hurt to check with your medical provider even when you change your exercise habits. So that's a good thing to do anyway. This always makes me encouraged. This is Dr. Dean Ornish. Who's ever heard of Dr. Dean Ornish? Oh, lots of you have. Good. You remember the kind of research he's done? He did, what's one of the things he did? You remember him starting with heart disease back in, it must have been the 80s. Late 80s, early 80s. And he found that people who changed their diet, they could do something about their heart disease. And then he started working on telomeres and prostate cancer. Now, telomeres are what those things we have that as they get shorter, the less our lives will be, the less length our lives will be. If they remain long, we'll have a longer life. Then he took men who had prostate cancer, changed their diets. Good things happen. Then, now he's working evidently on breast cancer. He's so well known now in his approach of changing lifestyle and diet to more plant-based that Medicare even approves his programs. And he says, the more the people in my studies changed their diet and lifestyle, the more they improved and the better they felt at whatever age. Wow. When I saw that, I thought, I get to choose how healthy I want to be. I may not be able to undo my genetics, but I sure can undo what I've been putting on my plate. And that's what he found made a difference. And I walk with this young woman whose husband is a doctor in the community, and she said this is what her husband says to her patients, their patients, her husband's patients. What I do for you is very small. What you can do for yourself, it's huge. And that's the way he begins his appointments with them. Wow. That's what we're talking about in Chat and Chew, too. We have a part in this, don't we? That's what it's all about. So let's find out what today's going to be about. Well, first, we're almost finished with the introductions, and then our speaker, Dr. Dustin Rudolph, will be speaking with us. And I have some sad news. Vanessa, sorry, is not going to be able to be here today. I read an email this morning and was so disappointed. Something has happened that she just cannot be here. But Dustin has talked to Vanessa and interviewed her on his website, so we'll be sure and share that with you if you want to take a look at it, and you can get to know her too. Then we'll have Nat West with a repeat performance of that hilarious song that he wrote after he watched those commercials on television about medications, all the side effects. I think you'll enjoy that song. So we're looking forward to that. We'll finish with closing announcements and door prizes. And one other thing is that little tiny pink lavender piece of paper, we're going to do something with it at the end of the meeting. So hold on to that and your ticket for your door prize, and we'll have those. Okay, so let's go ahead now and get started with our introduction of Dustin, and Karen Abdul Hamid is going to introduce him for us. And some of us got to see Dustin already, and so some of us already have copies of his book. But by the way, it will be for sale at the end of the meeting if you're interested in it.
Hello. I first want to say thank you to Dr. Dustin for generously giving us his time today. We are very fortunate to have Dr. Dustin here to share his wisdom. He will educate us. He will empower us. How do I know? I had the pleasure to hear him give an enlightening speech. I also read his comprehensive book, The Empty Medicine Cabinet. So please give Dr. Dustin a warm chat and chew welcome.
Before I get started, I just want to thank Kathy and the Chat and Chew group here for having me. It's wonderful to have you all here. Just seeing you all here tells me that you're interested in your health and that that's important to you and that's a priority in your life. So I really commend each and every one of you for being here today because of that. I have a sliver of Irish in me, so I'm going to say Happy St. Patrick's Day. Probably not enough of a sliver to wear green, to remember to wear green. So I'm probably going to get pinched a lot today, but I see we have some very festive audience members, and I love that hat of yours, by the way. So that's gorgeous. Today I'm going to talk to you about medications. I'm going to talk to you about food, food over medicine, and it's called The Secrets to an Empty Medicine Cabinet. That's the name of my book is The Empty Medicine Cabinet. I really wrote this book because early on in my career I had no idea about nutrition, the fact that what you put into your mouth, the foods and beverages have anything to do with health. I had not a clue. And then it was 8 years into my career that I figured out that I read the China study, and then I found out that what we put into our body has a huge effect on whether or not we have a chronic illness, how many medications we're on, how well we feel, and how we live our life on a daily basis. So I really wanted to come out with this information and put it in an easy to read format for people to get and as a resource. So I called it The Empty Medicine Cabinet because nothing makes me more proud than to find patients who are not on any medications or on very little as they go through life. I'm actually, go back, just to introduce a little bit more about my background. I started out in retail pharmacy right out of school. I was in retail pharmacy for about 4 to 5 years. So I've seen that end of the spectrum with that. Now I'm in hospital pharmacy. I switched to hospital pharmacy in 2006, so that's about 10 and a half, 11 years, going on 11 years. I'm currently still a full-time hospital pharmacist, so I still work in pharmacy. I'm still a pharmacist. So I see that end of the spectrum. I see people coming into the ER all the time with the heart attack, the stroke, the broken bones, all kinds of stuff that they come into the ER with and into the hospital with. So I've seen that end of the spectrum, and I've seen what the food can do too. And by far, food works so much better than medicine for most of the chronic illnesses out there. If you break your bone in an accident or something, a bowl of 3-bean chili is not going to help you. I'm sorry. You're going to need the medicine. You might need the surgery. But if you have heart disease, diabetes, autoimmune diseases, cancer, all these diseases that plague us in America, the medicine should really be used as a last line resort, not a first line therapy, which is what we do now. And we really need to refocus on the food instead. So we use actually a lot of medications in this country. Did I skip forward? Well, first, what is optimal health? So when I think of optimal health, I try to break that down, and health is the definition of health is the absence of disease or illness. So in America, I think we think that health is being on a bunch of medications and treating our diseases, and that's health. We go to the doctor, we get pills, we go to the pharmacy, we get those, we take those, and now we're healthy, right? Well, that's not the actual definition of health. The actual definition of health is the absence of disease or illness. And optimal is obviously the very best that you can be. So optimal health is the best that we can be with the absence of disease or illness. So we really need to change our focus and what we think of in terms of what is health and how we define health in this country. Because health is not being on a long laundry list of medications and going to a numbers of doctors' offices and what have you. That is that really is disease. That's disease care. And we call it a healthcare system, but it's really a disease care system. So we use a lot of medications in this country. You can see we use, in 2010, over 3.16 billion drugs were ordered or provided in physician offices, in hospitals, and in hospital emergency rooms. And that's a lot of medications. If you take the population of the United States, that's a little bit over 300 million, about 320 million, I think, was in the last census. So if you divide 3.16 million by 320 million, you're above 10 prescriptions for every man, woman, and child walking around in this country. And I don't take any prescription meds, so somebody else has taken my fair share, and I know some of you probably don't take them, so you know that's a lot of medications that we're on in this country. And that's a lot of money spent on health care. So what does that get us? Really, it just gets us a lifetime of more doctor visits, more blood pressure readings, more blood glucose readings, more hospital visits and overnight stays. It just gets more and more medical care because these medications that we take in, they have side effects. And so one will maybe interact with another, or we'll get a side effect and then we'll be on more meds. And so we keep going back to the doctor to try to figure out what our problem is. And unfortunately, once you get into that path, once you go down that path, it just kind of snowballs. And it just keeps going and going, and the list of medications get longer, and the list of doctors and specialists get longer, and the trips to see all these people get more and more. And you know, is that really what patients want? I don't think so. I mean, I haven't met a patient yet that wants to be on more pills and see more doctors and end up in the hospital more. They all want less. I have patients say to me all the time, man, why do I have to take these pills? Like, I don't want to be on these pills, especially for the rest of my life. So it's important to understand what we're getting for our money. Now, a lot of times people will see me and hear me talk and hear my message, and they'll be like, well, you must be completely and totally against all medications. And so do the pills work? I will tell you, yes, they do work, but they don't work as well as we had hoped them to, or that we think that they do, what we've been led to believe that they do. So the pills do work. They help us manage the disease, but managing the disease is not the same thing as getting rid of the disease. There's a big difference there. So really that leaves a lot of patients with a lot of unanswered questions. They're, like I said, they're going to different doctors' offices, they're ending up in the hospital, they're standing in line at the pharmacy, and people just want answers to their health. They want to know, what can I do myself to put myself in a position to live well and be well and get that time with my grandkids and get that time to see my daughter or son get married or graduate college or high school. And that's what people want out of life. So there's 3 things that we really need to focus on to get that kind of a life. And those 3 things is optimal nutrition. We need to move our body, regular physical activity, and then we need to have other positive lifestyle choices. So when it comes to nutritional excellence, that's a whole foods, plant-based diet. A lot of what we talk about at Chat and Chew here, what Kathy's group here has done, talking about removing the animal products and removing the processed foods or dramatically reducing those. As far as physical activity, you got to move your body. So you don't have to be an Olympic weightlifter. You don't have to win an ultra marathon or anything like that if you don't want to. If that's your thing, then great. All you have to do is just move your body on a regular basis, on a daily basis. And then as far as other positive lifestyle choices, these have been beaten into our head. Avoid smoking, don't drink excessively. We know that. We've known that for decades. You need to get enough sleep. That's very, very important. Sleep is just as important as many of these other things like exercise and avoiding smoking. So you should always look to get at least about 7 to 9 hours of sleep a night. It helps reboot your immune system. That's when your body is able to reboot itself and refresh itself. And anybody knows, I know, I work overnights at the hospital, so my sleeping schedule transitions back and forth. I do 7 days on, 7 days off. And when I'm transitioning, my sleep gets all messed up, and I can tell it takes a physical effect on my body. So sleep is so important. And then actually, this last one right here, positive relationships, in the Blue Zone studies, they looked at areas around the world. I don't know if any of you are familiar with the Blue Zone studies, but they looked at areas around the world that have the longest lived people. And there's 6 or 7 areas. And what they found is that amongst all of these places, they did eat mostly a plant-based diet, but overwhelmingly, all these places had a sense of community and support. And they had loving relationships, supportive relationships of people who are close to them. And that was so important to longevity. So that's very important too. Okay, now I'm going to get into the nitty-gritty. I'm going to start talking about statistics and drugs to let you know exactly how this works. Anybody watch the nightly news at night? Okay, like every 5 minutes there's a drug commercial on, right? And they go on about how well the drug works, and then they list off a whole bunch of side effects at the end. So they say maybe my drug causes 30% less heart attacks, or it's 40% less diabetes, or makes an improvement of so much percent of whatever disease it's treating. You've all heard that, right? Well, where do they come up with those numbers? And this is really, really, really important to understand, because just a little bit of tweak in the numbers can make a huge difference in what the actual success rates are and what are reported. So let's say, and this is a topic of absolute versus relative risk. So those two terms, key in on those two terms. Let's say I make a drug, and I want to use this drug to prevent heart attacks. And so I'm making this drug for heart disease. I have to go to the FDA and show them studies that my drug works, that it's safe and effective. So I'm going to take my drug. Before I go to the FDA, I'm going to get a group of people, maybe a couple hundred people, and I'm going to split them up randomly into 2 groups. Maybe I have 100 in this group and 100 in this group. One group I'm going to give the drug X. One group I'm going to give the placebo pill, which does absolutely nothing. It's a sugar pill. And then I'm going to follow these people for, say 5 years, however long the study is going to be. And so since I'm making this drug, and the whole point of you taking this drug is to prevent heart attacks, then I want to see who has heart attacks in the drug group and who has heart attacks in the placebo group. So after 5 years, let's say that in the drug group, 2 patients out of 100 have a heart attack. In the placebo group, 4 patients out of 100 have a heart attack. So did the drug work? Yes, it worked, because 2 is less than 4. So the drug group, there was less heart attacks. So the drug did work. But how does the success rates look? How successful was this drug? And when you look on TV, they're going to give you the relative risk reduction. They're going to say that this drug led to a 50% reduction in heart attacks. Where did they get that 50%? So is 2 half of 4? Yes, it is, right? That's 50%. So was there more than 6 people in this study? Of course there was. There was 200 people in this study. So if we just forget about the other 194 people, there was really a 50% reduction in heart attacks. So that drug that I made looks really good. Looks like it works excellent. It's phenomenal. But that's relative risk reduction. The absolute risk reduction is a 2% reduction in heart attacks. So we're looking at the same study, the same data here. Now, how do they get the 2%? Well, 2 out of 100 is 2%, and 4 out of 100 over here is 4%. So we really, when you take all the people in the study, we really went from a 4% heart attack rate in the placebo group to a 2% heart attack rate in the drug group. So we really only reduced it, the amount of heart attacks, by 2%. And that's taken everybody into account. And I don't know about you, but if I'm going to take a drug and it's been in a study to show how safe and effective it was, I want to know everybody in the study, with everybody in the study, how well did the drug work? And that's the absolute risk reduction. So you see how that makes a big difference? One little tweak in the numbers on how you come up with the results, and you can make your drug look fantastic. Or you can be honest about everybody in the study and tell it like it is, and that's the absolute risk reduction. So you need to know that. So now I'm going to go over aspirin in heart disease. These are absolute risk reduction numbers. So this is reviews of everybody in studies that were on aspirin. Now, to prevent a first heart attack or stroke after 1 year, aspirin helped avoid no deaths. Nobody was helped by avoiding death. And you can see just a fraction of a percent were helped by avoiding a non-fatal heart attack or non-fatal stroke, and about 0.03% were harmed by a major bleed, because aspirin can cause thinning of the blood, and it can cause bleeds. So you can see there that, you know, they always say when you get older you got to take an aspirin a day. And I'm not telling you not to take an aspirin. I'm not telling you to take an aspirin. What I'm telling you is that the absolute risk reduction numbers for aspirin on preventing heart attacks and strokes is right here, for those who have never had a heart attack or stroke and they're trying to prevent a first one. Now, to prevent secondary prevention, what that means, secondary prevention, is if you've had a heart attack or you've had a stroke before, then you take an aspirin. Does it work any better? Because that's a different patient population. That's a different group of patients. And you can see it does work a little bit better, but the absolute risk reduction numbers are still only about 0.5 to 1.5% there. You know, about 1/3% avoid death, about 0.5 to 1.3% avoid a non-fatal heart attack or stroke. So it does work better, a little bit better. And then you still have about 0.25% that have a major bleed using the aspirin. So you'll find this with a lot of drugs. When you start looking at absolute risk reduction numbers and then side effects that can be caused by these drugs, the numbers are actually really low on the total amount of people who are actually affected by it. So most people get absolutely nothing from taking drugs. So they take the drug and maybe they're in the 97 or 99.7% that, you know, nothing happens to them, or 99% that nothing happens to them. So you just need to understand where this data is coming from and what it means. Now, one thing I want to point out, the NNT.com down here, the numbers needed to treat physicians group, they're a great resource. So you can write that down, the NNT.com. You can go on their website. They have these reviews, and they give the absolute risk reduction numbers for a lot of different medications in different disease states and scenarios, medical conditions. They give absolute risk reduction numbers for things like mammograms and prostate screening, the PSA test, things like that. So it's a really good resource to have. Okay, how about statins? Because everybody knows about statins. I've heard the saying before that some, you know, I think one physician, I don't know who it was, but they said we should just put statins in the drinking water, because in America everybody has high cholesterol, so let's just put statins in the drinking water. Now, that's crazy, I think, but how well do statins work? So the NNT again has this information, and when you looked at statins to prevent a first heart attack or stroke after 5 years, the evidence wasn't really that convincing. Nobody avoided death, and only between 0.5 and 1.6% avoided a non-fatal heart attack or stroke. So it worked a little bit better than the aspirin for that scenario, But look at the side effects. 2% of people get diabetes from taking a statin, and 10% have muscle damage. So that's a common side effect, actually. People have muscle damage, muscle aches, muscle weakness. There's a very severe condition called rhabdomyolysis, where it's muscle wasting. And that happens in, I think it's less than 1%, but that can also happen. So a lot of people have muscle problems, and then they have to get off the statin or maybe switch to a different one. Statins for secondary prevention. So again, secondary prevention is if you've already had a heart attack, you've already had a stroke, now you take the statin. It does work better in that case. You can see that at least it helps avoid death in 1.2% of people who take it. And then you get about a 0.8 to 2.6% reduction in either stroke or heart attack risk. So do the drugs work? Do the statins work? Yes. But they certainly don't give you a 35 or 40% reduction in heart attacks, which is what they might say on TV or in a magazine ad or on a radio ad. So just to understand that. How about diet and heart disease? This is very important, because this works so much better than aspirin or the statins. And again, just like I tell people that I'm not here to tell you to take a pill or not take a pill, I'm just presenting the information so that you can make an informed decision. I also don't tell people to eat or not eat a certain way, because I'm not them and I don't have to live their life, and I shouldn't tell or dictate to somebody what they should or should not eat. But I'm here to tell you what the evidence says. And with a whole foods plant-based diet, this is Dr. Esselstyn's study. You might have seen this before, but I think it came out in 2014, the summer of 2014. After 3.7 years of follow-up on Dr. Esselstyn's whole food plant-based diet with no oils, no animal foods, and no processed foods, he had a total of 177 compliant patients. 81% of them saw improvement. 81%. Can you imagine if a drug would give 81% of a benefit to people that were taking it? So with improvement, that meant symptom reduction or actual reversal of their heart disease. Now, I don't know of any drug that actually reverses heart disease. So diet has actually been proven to reverse heart disease. It's something that we've accomplished with diet that we've never been able to accomplish with pills. Another 8% remained stable, so that means they halted their heart disease right where it was. So that's about 89%, or 9 out of every 10 people that went on his diet that got better. Well, what about the other 10 or 11%? What happened to those people? And so they experienced worsening of disease. But if you actually read the study, I actually read the study, what happened is many of those 10% of those people, some of them had a heart dysrhythmia, which is an electrical current problem in your heart. It deals with the electricity in your heart going haywire. That's not the same thing as clogged arteries. We can take this diet and treat clogged arteries and halt and reverse it. But you can't take a whole foods plant-based diet and take somebody that has a heart dysrhythmia, that has an electrical current problem with their heart, and reverse that problem. You can make their heart work better and have unclogged arteries and just work more efficient, but sometimes you still need the medications to treat those heart arrhythmias. So in this case, some of these people just stop their meds in those kind of cases, or they just refuse to go on medications if they had a heart condition that required it. I think one patient refused to start warfarin for atrial fibrillation, which is a heart dysrhythmia. So that thins the blood and prevents heart attacks and strokes. So it wasn't necessarily due to the failure of the whole food plant-based diet that these 10% of people got worse. It was due to other factors. And really there was only one person who could be fully attributed to being on the diet and they had a stroke. So one person out of 177 people. Now if I had one person out of 177 people on statins who failed or got worse, that would be a miracle. But I've never been able to do that with patients if they're on a statin or on aspirin or some other medication. A statin is like Lipitor, Zocor, Pravachol, Lovastatin, those medications that work to lower cholesterol levels. So that's a good question. It was good to clear that up. Okay, now I'm going to talk about diabetes. Because diabetes is really just skyrocketing now in this country. If you look, I believe it's about 80 to 90 million people either have diabetes or pre-diabetes in this country. So it's almost 1 out of every 2 to 3 people have diabetes or pre-diabetes in this country, and it's getting worse. And the more weight that we gain, the more diabetes that we're seeing, type 2 diabetes. So with type 2 diabetes, one of the first medications they put people on is metformin. And metformin, the way that metformin works is it tells your liver, so your liver is just a big storage tank, and so when you eat and you take in food and nutrients, and you're not going to use all the nutrition that you're eating, all the nutrients that you're eating. So what the liver does is it stores a lot of those glucose molecules that are left over that you don't need right then, and it stores them for later on when you're not eating, and then it releases that glucose into the blood when you're not eating so that you have something to make energy with. Well, metformin tells the liver not to dump out that glucose into the blood. So if you're diabetic, that would kind of make sense because you already have too much glucose in your blood and you don't want the liver to dump out a bunch more. So that's how metformin works. Metformin is one of the first-line therapies with diabetes, and they looked at preventing morbidity or mortality after about 10 years of people being on metformin. All that morbidity and mortality is death and disability. And what they found is that 6.3% were helped by avoiding a heart attack, 10% were helped by avoiding any kind of a diabetic complication, because diabetes comes along with heart disease, comes along with infections on the foot, comes along with peripheral neuropathy, which is numbness of your nerves, comes along with blindness, kidney damage, all kinds of things like that. So about 10% of people were helped by preventing one of those complications by taking metformin. And then 5.3% were helped by avoiding death due to diabetes. So certainly metformin has better success rates in terms of treating diabetes than the statins had in terms of treating heart disease. But still, if you look at these numbers, they're pretty low. I mean, it's between 5 and 10% of people are benefited by taking metformin. And then, of course, every drug has side effects, and you can see that about 2 to 12% of people have GI side effects. So diarrhea, nausea, vomiting, those kind of side effects. And that's mostly like in the glucophage or metformin extended release products. If you use the immediate release products, at least right away when you put people on those, you have to start them on a low dose. Sometimes this number will go up to even 40 or 50% of people having GI effects when they first start on metformin. And then they slowly get used to it and it goes down. So type 2 diabetes, the medications, they help manage the disease. They do not cure the disease because they do not address the root cause of type 2 diabetes. So there's 12 classes of type 2 diabetes, or 12 classes of diabetes medications. None of them address the root cause of diabetes, because the root cause of diabetes is insulin resistance, and insulin resistance is caused by this excess fat that ends up in our muscle cells. So it's really important to understand this, and I got a little picture here so you can visualize this. This is a normal cell. These two lines here, curved lines, are the cell membrane. This is inside the cell right here. This is in the bloodstream out here. So what happens is when you eat, your body, your brain will tell your pancreas to make insulin. And insulin comes out because when you eat, you have carbohydrates that are broken down into little glucose molecules, and that's what your body uses to make fuel. So those glucose molecules trigger your brain to tell the pancreas to make insulin. The insulin will float around in the bloodstream, and this is a muscle cell. So it'll find an insulin receptor on a muscle cell membrane, the outer membrane. It'll attach to that membrane. And then what happens is a series of chemical messengers inside the cell will tell this little molecule here, which is called a glucose transporter 4. So I just call it a GLUT4 transporter. It tells this little guy right here floating around inside the cell to go up to the membrane and open up its doors and let the glucose from the bloodstream into the cell, into the muscle cell, so that that glucose can be used to make energy. And so your muscles can have energy. Does that make sense? Okay. So these little yellow blobs here are intramyocellular lipids. And intra means inside, myo means muscle, and cell is obviously cell. And then lipid means fat. So those are just little fat molecules inside your muscle cells. Everybody has them because everybody doesn't eat 24/7. And when we're not eating and we're fasting, we still need something to help us make energy. And so fat is a great way to store energy. So our body naturally has this. I have these in my muscle cells. And when we need them, our body will call on these things to make energy when it doesn't have the glucose from eating. Okay, this is a type 2 diabetic cell. You see the difference? There's a whole lot more of these little intramyocellular lipids. So there's a lot more fat that clogs up into the muscle cells. Now, what does that do? That does a number of things. First of all, number one is it decreases the number of insulin receptors on the cell surface. There's a bunch of these insulin receptors on cell surfaces of the muscles. So it decreases those by up to half. It's been shown in animal studies that when you have all these extra fat molecules in the muscle cells, the number of insulin receptors go down by half on the cell membrane. So that's less receptors for insulin to find in the first place. And if insulin can't find the receptor, it can't do its job. If there are receptors left, these little fat molecules block insulin from attaching. And then if insulin does happen to attach and get past that, then it blocks these messengers from telling this GLUT4 transporter to go from the cell up to the membrane, inside the cell up to the membrane, to let the glucose in. So all these different spots, these little fat molecules can cause problems. So there's a number of different spots that can cause problems here. So you can see how if we can't get glucose from the bloodstream into the muscle cell, then the blood sugar level goes higher. And that's what diabetes is. So diabetes is not caused by eating too many carbs, because the carbs are right here. The carbs are broken down into glucose. But the glucose is not causing the problem. The glucose is good. The glucose is energy for your body. Your body just can't use that glucose because these fat particles are clogging up and gumming up the whole system. So type 2 diabetes is caused by these extra fat molecules. And this whole process right here is called insulin resistance. So they do a very good job in school, in pharmacy school, medical school, dietetic school, talking about insulin resistance, but they don't talk about what causes insulin resistance. So that's why if you go to your doctor or your pharmacist or even a lot of times your dietitian, and they've just gone through schooling and they haven't done any research on their own, they're not going to have a clue about any of this. So they don't really know to even tell you that this is the cause. Yes? Correct. Yeah, most of type 2 diabetics are overweight or obese, but there are some that are normal weight or thin. But this process still happens inside their muscle cells. Because if you're overweight or obese, the fat is not only on the inside of your muscle cells, but it's also, where we don't want it, right here and right here. So you're seeing it on the outward appearance. But even in thin people with type 2 diabetes, this is a problem. Okay, so how about a whole foods plant-based diet in treating diabetes? Now this is naturally low in fat. Anywhere from 7 to 20% of the calories are from fat. So this addresses the cause of the insulin resistance, which is the fat intake of our diet. So if we get our calorie count from the fat down to 7 to 20%, we can halt and even reverse type 2 diabetes. And that's what they found in studies, is that when you put people on this diet, you have weight loss, of course. You have lower HbA1c levels, and that's the HbA1c level is just basically a 90-day average of your blood glucose levels. So you want that to go down. You have added, I guess, side effect, I guess you could say, of lower total and LDL or bad cholesterol levels, so your cholesterol levels go down. And then actually 71% of study participants who have went on this diet in this particular study were able to reduce or eliminate their medications. Now that's pretty telling. I mean, if you can get a diabetic off their medications or on lower amounts of medications, I mean, I'd love to hear that. And I'll finish with prostate cancer. So I covered heart disease, diabetes, and now I'm going to talk about cancer. Cancer is the #2 killer overall in America, and prostate cancer is one of the most common cancers in men and in this country. Now, for prostate cancer, Dr. Dean Ornish, like Kathy had talked about, has done studies on using a whole foods plant-based diet and prostate cancer, and he's done some wonderful work. He's found that people on this diet for 1 year were able to reduce their PSA levels by 4% on his diet, on the whole foods plant-based diet, whereas 6% of people who were on their controlled diet, so they stayed on their Western style diet, high-fat diet, there was a 6% increase in PSA levels. And what PSA is prostate-specific antigen. So you just take a blood test of these men, and you can test for this prostate-specific antigen. And typically, the higher the PSA level, the more of a chance or risk that you have prostate cancer. Now, it's not foolproof. It's not 100% accurate. A lot of times there's false positives or false negatives. But it's the best thing we have other than actually going into the prostate, cutting part of the prostate out, and sending that to the lab. So you can just do a quick and easy blood test. So that's amazing that we were able to, that Dr. Ornish was able to take people, put them on the same diet that helps heart disease and type 2 diabetes, and actually see a reduction in PSA levels. So effectively halting and reversing these people's prostate cancer. In the group that was on the whole foods plant-based diet, no additional treatment was required. In the group that was on their Western type diet, 6 of the 49 men required additional medical treatment. So the people who were on the whole foods plant-based diet got better, didn't need any more treatment. People who were on the standard diet that they have grown up on the Western diet, they got worse and they need more treatment. Now that is the only cancer that I am aware of that we have data specifically on a whole foods plant-based diet long term, like a year or more, on treating that cancer and on these kind of results. Hopefully more will come out as time goes on. I think there is some work out there. I think Dr. Furman's actually working on some breast cancer studies. So right now, we don't even have any data on absolute risk reduction for morbidity and mortality, which would be nice because that's death and disability. And if anybody has cancer, they want to know if they're going to die or be disabled from the cancer. Well, we don't have that. This is the best that we do have with some blood markers that Dr. Dean Ornish has shown us, which is still very helpful. And again, I just want to reiterate that not all cancers are created equal. It's very important to, if you have cancer, to do your due diligence because not every cancer reacts the same way. Breast, prostate, and colon cancer do pretty well with dietary changes, but I think also sometimes leukemia and lymphomas can do pretty well. But some other cancers do not, I mean, they're not harmed. You're not harmed by going on a whole foods plant-based diet. You get better overall with your health, but it's not the cure-all. So don't think that no matter what cancer you have, you can just go on this diet and it'll fix everything. You really need to do your due diligence. And if you want some resources, I actually wrote an article, and you can just Google cancer answers and plant-based pharmacist, and I have an article on there, and I have links to the National Cancer Institute, and they list all the different cancers that are out there. They explain what the cancer is and how it's treated. And then I also have a link to Dr. Ralph Moss's website, cancerdecisions.com. And he has looked at both alternative and conventional treatments in treating all kinds of different cancers. And he does sell reports of his research and literature. So that is two really good resources that people have. And I think with that, I just want to end before we do a little Q&A here. We're going to do a Q&A? Okay. Before we do a little Q&A here, I always like to tell my audience that you're only given one life to live and one body to live it with. So make sure that you take care of that body, because it's the only one you get. So thank you very much, and I'll take questions now.
Thank you very much. The presentation was enlightening. I am a firm believer. I am on a vegetable diet and mostly raw. I do a little bit of cooking, and I was able to reduce my coumadin level to a 5 or 7 when I was mounting to a 10. So I think that, I really believe that it has helped me tremendously. And I am not very fond of meat. I may have a little chicken once in a while, but it's mainly celeries and carrots and all of the different, and I've been on it now for about 7 years, and I've been on Coumadin since 1995. So my Coumadin was, it's a blood disease. It's a, what do you call it?
Do you have atrial fibrillation?
No,
no, okay.
No, I have Leiden factor 5.
Okay, a blood clotting disorder?
Yes,
okay.
Yes, it's hereditary.
Yep.
From both my mom and my dad, unfortunately. But I commend you, and try it, really. Put the vegetables in your diet, and you'll see a difference. Your skin also changes.
Absolutely.
And it doesn't take a lot, and you lose weight automatically. It's just great. More energy. You're not hungry, and when you do pick, celery does it, and it puts you off sugar. And sugar is one of the main feeders of cancer. So you really, really have to be vigilant if you want to live longer. Thank you.
Well, I really commend you for switching your diet over and for making those improvements. That's fantastic. I think she's an example right there of what you can do with your diet. Even though that there is a blood clotting disorder that she suffers from, which is genetic, and it is a rare, the factor V Leiden is a rare disease. It's not common out there. But those are the situations where, it's not just clogged arteries. There is a need for medication sometimes, and that's kind of a situation where there might be a need for medication to help thin her blood, so she doesn't. So you don't. Yeah, what the warfarin does is it thins the blood so you don't get blood clots. It helps prevent blood clots that can be life-threatening. And one thing I want to just mention with warfarin, if you're on warfarin, or Coumadin is the brand name, that is vitamin K sensitive. And you might have heard that, I can't eat any greens if I'm on warfarin or Coumadin, because greens have vitamin K. They're very rich in vitamin K. So I can't eat greens, or maybe you've been told you can't eat greens, and that's not the case. So you can eat greens. It's just that you want to be very consistent with your greens. Don't go binge eating greens on St. Patrick's Day here, and then tomorrow and the next day don't eat any greens, and then binge eat on greens again. You just want to have the similar amount, the consistent amount of greens in your diet every single day, and then that will help regulate and stabilize the warfarin, because warfarin, you have to go in every once in a while and get a blood test. It's called an INR, to make sure that you're not getting too much, you're not getting too little. So you don't want to be at risk for too much and side effects. You don't want to be at risk at too little and not preventing those clots. So it's very finicky, that medication. So you just have to watch that. So I just wanted to mention that.
I have my own
Oh, you can check it at home. That's fantastic then. That's great. Yes.
Hello. I'm wondering if you are aware of any research regarding whole plant-based diet and calcium, bone calcium loss.
As far as like osteoporosis or?
Yes.
Okay. Yeah, so as far as that topic goes, osteoporosis is actually, well, there are studies out there, and what they've done is they've looked at hip fracture rates with various countries all over the world. And they've seen how many cases of hip fractures per so many people there are in that country, and then what their dairy consumption is. And what they found is that the more dairy and cow's milk consumption there is, the higher the hip fracture rate goes. And hip fracture rate is a direct correlation of osteoporosis. So I know that I grew up, many of you probably grew up the same way, being told that we need to drink our glass of milk or multiple glasses of milk a day. We need to get our dairy for strong, healthy bones to get that calcium. Well, that's actually having a negative effect, because the more dairy consumption we have, the more hip fracture incidence we have, and the higher osteoporosis is. So there was actually there was a journal article, I think it was in the American Journal of Clinical Nutrition, about maybe about 10 years ago, and they looked at calcium intake and what the body actually needed to replace calcium loss in the body. And in that particular journal article, it says people that had adequate amounts of sodium and protein intake in their diet only needed about 500 milligrams a day of dietary calcium to meet their body's needs. Now, that's kind of hard to decipher if you don't know a lot in depth about nutrition, but adequate amounts of sodium and protein is a whole foods plant-based diet. We only need about a minimum of right around 250 to 500 milligrams of sodium per day in our diet, and you can get that just eating fruits and vegetables and enough to fill you up. And as far as protein goes, we only need about 35 to 55 grams per day for each person. So on a plant-based diet, you get about 60 to 80 grams a day of protein. So if you're eating a plant-based diet, a whole foods plant-based diet, you're getting plenty of sodium, you're getting adequate sodium and adequate protein, and you really only need 500 milligrams a day of calcium too. Not the 1,500 milligrams or 2,000 milligrams that oftentimes get told the patients to supplement with. So if you're supplementing with calcium, you can actually go on my website too, because I have a whole article on this subject on supplementing with calcium. You wanna be careful. If you have a calcium deficiency, you may need it, but you're not going to know that unless you have your doctor check you out. Most people take calcium because they think they just need to take it for their bones, because they want to have strong, healthy bones. But actually, calcium supplements have actually been linked to heart attacks and to strokes in the medical literature, because it's been shown to calcify a lot of those plaques inside our arteries, and it actually can increase the risk of heart attacks and strokes. So that is a side effect that many people don't think of when they just go and buy calcium tablets over the counter. So just be aware of that. And if you want more in-depth information, just go on my website, which is plantbasedpharmacist.com, and search for calcium. It should be on the frequently asked questions page. And the kidneys, see, all the organs are connected via the circulatory system. So the blood vessels go through all of our organs, so it can affect the kidneys, and also calcium oxalate crystals or calcium oxalate stones are one of the more common kidney stones that people get. So if you're taking calcium supplements, and you're at risk, or you've had kidney stones in the past of calcium oxalate, you can possibly be more at risk for that too.
And I'm going to interrupt for a minute, because this is a new book that's just been published. There'll be a door prize, the cheese trap, and It's by Dr. Neil Barnard, and he speaks to that overabundance of calcium and how it's related to heart disease. I was just reading that chapter yesterday morning, so maybe you'll win the door prize so you can read this book, because it's really helpful too. Okay, we have another question.
Being married to someone who's had 1 heart attack, 3 strokes, diabetic, has cluster headaches, restless leg, I would look forward to a empty medicine cabinet.
Yes.
Presently, there's 13 prescriptions that's stored in that medicine cabinet. But my most pressing problem is, what is the difference between Nupro and ropinirole?
Nupro. I'm not familiar with Nupro.
Nupro
Is it a patch?
It's a patch.
It's a patch. Okay. Okay. I'm not too in depth familiar with the Nupro because it's a newer agent, but ropinirole has been around for a while. You're talking for like restless leg syndrome? Is that what you're taking?
Restless leg and Parkinson's disease.
Okay. Yeah.
And the really bad thing about Nupro is that it has put us in the donut hole in 3 months. It's $934 a month. Luckily, we pay $75 copay, but we're in the donut hole now. So.
Well, a lot of times what the drug companies will do is, once their patent runs out on a drug that they've had out for years, they'll try to find a way to maybe change a little part of the chemical part of the molecule and have a similar effect, whether it's another pill that they come out with and they just call it a different name, or they put it in a patch, like with Nupro, or put it in some other form of medication or some other dosage delivery form, and then they'll have a patent for another so many years, so they can make more money. So don't be don't feel that you have to take that if it's causing financial burden to you. You can talk to your doctor about taking older medications that have worked in the past.
Well, he's pretty hung up on the patch. However, there was something very enlightening in your presentation. When I get on a treadmill about 3 times a week, and once you said that sleeping was as important as exercise, I decided to double up on sleeping.
There you go.
And stop
there you go. There you go. It is important. It's very important.
That's a good one, yeah. And how many have trouble with sleeping? Yeah, I think as we get older, it's a problem.
Take longer. I take Atovastatin, whatever it is, anyway, one of those cholesterol pills.
Atorvastatin?
And I finally persuaded my doctor to let me, I thought maybe just half it, but he said, well, just go off of it, for 2 weeks or so. Well, anyway, I went off for 2 weeks and I took the test again, but I haven't had the result. But in addition to heart and stroke, I understand that it was supposed to be helpful for Alzheimer's and so on, prevention. Have you ever heard of this, and is this the case?
Well, I know that there's beta amyloid plaques in the brain with Alzheimer's.
I'm sorry, I'm not understanding.
There are plaques in the brain that develop for Alzheimer's. So I'm not familiar with the research on how well or the success rates, if any, that statins have on Alzheimer's. To be honest with you, I don't even know if it's been studied long enough to really get a good idea on if it works for that. But again, Alzheimer's is a disease that can largely be prevented just by going on a plant-based diet and starting as soon as possible in life to eat healthy. The sooner you start, the more that you're able to prevent something like that happening.
Years ago, I persuaded him to let me go off, and then my cholesterol did spike, and I went back on it. And I don't like taking medicines at all, period. But I figured that I better do it. And now I don't know when I hear the results, I'm afraid it's going to have gone up again since I'm off of it. And I don't know whether I should try to go back on it or not.
Well, what I like to tell people with that are on cholesterol medications, whether they're on statins or some other cholesterol medication, is that the science has shown that when you get your total cholesterol down to 150 or below, you're pretty much heart attack proof. Dr. Esselstyn's shown that, and Dr. William Roberts out of Baylor University has also talked about that. So that if you can get your cholesterol down, your total cholesterol down to that with just changing your diet, that would obviously be the best way to do it, to switch to a whole foods plant-based diet, and because there's no side effects to eating fruits and vegetables. But there is side effects to taking the statins, and a lot of people don't want to take them, just like you. Now, if you're between 150 and 200 for total cholesterol, I think the risk of some kind of cardiac event is about 30–35%. So there is still a risk if you're between that, and then above 200 is very high risk for a cardiac event happening. So when you're looking at, should I take a statin or should I not take a statin, just understand that those are the numbers and that's what the risks are. And that if you take a statin, let's say your cholesterol is 180, your total cholesterol is 180. Well, you're kind of between that 150 and 200 mark where you have, 30–35% chance of something, possibly a heart attack or stroke possibly happening. If you take a statin and you take it for 5 years, like I showed you, if you've never had a heart attack or stroke before, 0% of people were helped by avoiding death, and about less than 2% or 1% avoided a heart attack or a stroke by taking a statin. So that's the benefit that you're going to get from taking a statin. So, about what?
Wine. He's asked, the
Wine.
question was, what about wine?
Okay, so as far as wine and alcohol, it's not something I encourage people to include as a regular part of their diet. If anything, I think it should be a treat, because alcohol is actually shown to increase the risk of several different types of cancers. It's very carcinogenic. With anything that it touches, so your oral, pharyngeal cavities, anything in your mouth, your throat, down through your esophagus, your stomach, of course the liver. Also breast cancer is shown to increase. So there's a lot of different cancers that alcohol, the regular consumption of alcohol, and we're talking moderate drinking. We're talking 1 drink a day for women or more and 2 drinks a day or more for men. And it's been shown to significantly increase all those kinds of cancers. So I just like people to be aware of that. And if you choose to drink, I would encourage people to do it as a treat and not necessarily on a normal basis, regular basis.
Antioxidants that are in red wine.
Her question was, what about the antioxidants in red wine?
So, there is like resveratrol in red wine, and the same thing in purple grapes or red grapes, and other antioxidants that you may get. But when you look at it, you can get all those things in fruits and vegetables. You get the dark purple or the dark red colored fruits and vegetables, you can get those antioxidants as well. And you're also getting the fiber. You're not going to get any fiber in wine. So, and you get the increased risk in cancer if you consume wine on a regular basis. So you just have to understand that there's pros and cons to this. And I'm of the fan that if I can get these antioxidants and minerals and vitamins in food and not have to resort to something that can have some possible risk, I would rather go for the food that doesn't have any side effects. So that's my own take on it, but again, you need to decide for yourself what you feel comfortable with.
One of the things we learned from Dr. Clapper, too, was, remember he said, this was last week, he said, in the operating room, we take our instruments and we put them in alcohol to kill the bacteria. Mm-hmm. So he said, when you ingest alcohol in your body, you just kill some of your little friends who are taking care of you in your gut. So that was his other thing to consider as we go that way.
I just want to say that I thought the presentation, I'm sure everybody else did, was fantastic. And so we appreciate so much for being here, really.
Okay.
Also, you know, I think I can get you a job at Winter Haven Hospital.
Well, thank you.
Yeah, we sure would love to have you here. And I would also like to say to the audience, this is a wonderful opportunity to ask any question you may have to a real expert. So I hope that you'll take this opportunity to do that. Cool, wonderful. If you're on plant-based, just curious, and I'm sure the audience is too, about a multivitamin. Any thoughts on the multivitamin?
So as far as what I've found with vitamins in general, is that if you're on a plant-based, a whole foods plant-based diet, one thing I do recommend, and I do myself, is I do a B12 vitamin. I usually just do a daily B12 vitamin if I remember to take it during the day. But I'll do, you can do 5,000 micrograms a week, or 500 to 1,000 micrograms a day, whatever works for you. But a B12 is essential. It's good for forming red blood cells and brain health and cognition, and then energy-wise. So a B12 vitamin is very important to your nervous system and your blood system. That is not, there's only 2 vitamins that you can't get in food naturally, and that's vitamin B12 and vitamin D. Well, vitamin D you can get in some mushrooms, but for the most part, those 2 vitamins are you don't get them in food nowadays. So the vitamin B12 is made by bacteria, actually. So it's not just naturally found in plant food. So if there happens to be bacteria on your food, you can get a little bit that way, but it's usually not enough. So that's why I say a B12 supplement. And then vitamin D is from the sun. That's the best place to get vitamin D, is from the sun. And your skin actually will regulate how much of that vitamin D it takes from the sun and uses in your body. And it knows how to do that. Our skin is brilliant. Our body is brilliant. So it knows exactly how much to do and give you to function optimally. Now, for those that might be vitamin D deficient, that means your vitamin D level is less than 20. That's a deficiency. You may need to supplement with vitamin D. You're not going to know that unless you go get a blood test done. But in those cases, that's where you start to increase your risk of fracture risk with your bone health and mortality, so death rates. So you want to be above 20. And I've seen studies out there that if you're below 20, your death rate goes up with your vitamin D. And then if you're really high with vitamin D, say if you have levels, I think it was above like 60 or 80 or something like that. But if you have really high levels of vitamin D, actually you're increased in mortality rate, so your death rate goes up. Not as much as if you're low, but you can get too much and you can get too little. So those are really the only 2 vitamins I recommend. As far as a multivitamin, you can get everything in fruits and vegetables, so why pay for a multivitamin that you don't need? And then also vitamin A and vitamin E and folic acid have been shown in supplemental form to actually increase your risk of cancer. So you want to watch out for that too. Does that answer your question? Okay. Well, the vitamin D and the calcium work together because it helps absorb the calcium in the gut. But if you're, like I talked about earlier with calcium, if you're eating a whole foods plant-based diet and you're getting what you need in terms of sodium and protein, the minimal amounts, which everybody does if they eat healthy, then you don't need necessarily to supplement with calcium in the first place. Right.
Just what the gentleman who asked about the wine, I was going to ask you how you feel about kombucha and replacement of that, because I know with myself, it kind of cures my caffeine craving and my alcohol craving if I drink about a 16-ounce bottle of kombucha, and it helps with the gut bacteria as well. Mm-hmm. So.
Yeah, I have heard that. I'm certainly no expert on kombucha, but I do know that it does help restore some of the good bacteria. And it's certainly better than alcohol, because the alcohol does have that risk of cancer increasing in the body. So if it's something that you go from alcohol to that, you're definitely moving in the right direction. So I wouldn't say that there's any problem with that. I drink a lot of water myself, and then once in a while tea. I like green tea, iced tea, teas. So that's kind of what I stick to. But I don't know a lot of in-depth stuff about kombucha to tell you that if there's anything negative about it.
Go ahead. Can you ask it? Statins, do they cause diabetes? Is that what you said?
Yeah, about 1 to 2% of people who take statins will develop diabetes from taking a statin.
No, he's still sitting there.
I don't know how soon. I don't know as far as a time frame. That's a good question. That's a very good question that I don't have an answer for, actually.
Mm-hmm. We've got people in here to be good researchers.
Yes.
You ask good questions.
Did you have a question?
Yes. Is your opinion on probiotics the same as?
Okay. Can I repeat that question? Say it again.
On the probiotics.
Oh, what do you think about probiotics?
So as far as probiotics, that's another subject that I haven't really done in-depth research on. Certainly, our gut bacteria is very important, and there's more and more literature coming out how if we have good gut bacteria, that we're going to have less chronic diseases than if our gut bacteria was more of the harmful bacteria. So with probiotics, you're putting good bacteria into your gut through a pill. Now, I've just heard through, I think Dr. Pam Popper is a big fan of probiotics, and including those, especially with people with autoimmune diseases. But to speak to it as far as stats and studies and stuff, I don't have that knowledge to give you.
Well, I would recommend that, Dustin, you may want to look at it too. Dr. Clapper spoke to that in his Skype with us. And he also has it on his webpage. I sent that out in the, not the last email, but the one before that, because he has on his webpage specific probiotics that you would think about. But he also said, you know, it's just good to go ahead and start eating the whole foods, but if you're really working on leaky gut, that you could add to it.
And I've seen actually a lot of literature out there where it says that if you just eat plant foods with lots of fiber, that's what the good bacteria want. It's like a smorgasbord for them, that fiber in the plant foods. So if you just include more and more and more of those foods, your good bacteria are naturally going to multiply and start to outnumber the bad bacteria, and you can do it just with foods for most people.
Mm-hmm. Okay. We have a question from one of our live streamers. This is Jo Lynn in California, and she says she's talked with a doctor who says to her that if you are on 3 prescriptions, you are causing interactions. He said if you are on 7 drugs or more, then you're over the top and you have counteractions and interplay between these drugs. Would you agree with what he says or expand on that?
Oh yeah, the more medications that you add, the more complications and problems that there's going to be. And I wouldn't necessarily say that you have to have 3 to have an interaction. All you need is 2 drugs that don't work together, and you can have an interaction. And I actually find this in the hospital all the time. I'll have patients come in, they'll be on, say just a couple weeks ago I had a patient come in, they're on an antiarrhythmic called Tikecin. So it's for the heart, it's for a heart arrhythmia. You can't take certain antibiotics when you're on that drug because it can actually cause a prolongation of the QTC interval, which is the on the EKG, the heart rhythm wave, kind of spreads that out, and it can cause worsening of your heart arrhythmia and possible death. So sometimes I'll find that kind of a situation happen, and you know it just takes 2 drugs to cause an interaction. So I'll have to call the doctor and say, oh, you can't use this antibiotic, but you can use this one over here if you want to. So it's very important to be open and honest with your physician. If you're taking anything from another physician or over the counter or anything that you're taking, so that they know what your list is, and also your pharmacist too. Because a lot of people will go to multiple doctors, they'll be on multiple medications from all different doctors, nobody necessarily talks to one another, and then they'll go to 2 or 3 pharmacies, and they don't necessarily tell the other pharmacies what they're on at this pharmacy or this pharmacy. And so those are safety checks. Like if your physician knows everything that you're on and your pharmacist knows everything that you're on, they can look for those drug interactions so that when you get up to 7 or 10 medications, you're almost guaranteed something might interact. And if you have 100% forthright and honesty with your healthcare providers, then we can't catch that stuff, and then it puts you at risk. So it's very important to do that.
And we have another question from North Florida. This one is about the speeded up process of approving drugs. As there's talk now of doing that the FDA would shoot the drug approvals through quicker and supposedly help us. Is that a good idea?
I don't personally think that we should be speeding up the process of drug approval for most drugs, just because a lot of drugs get to market and then we don't find out about something that's harmful or hurts people until after it gets to market, and that's after years of research. Because what happens is they put these drugs in trials, and at first you're starting with just a small group of people, maybe a handful of people, and then you're moving up to 100 or 200 people, and then you're moving up to studies that do maybe 2 or 3 or 4,000 people. You can find out a lot about a drug during that process, but you're not putting it out there to millions of people. And it's once it gets released to the market to millions of people where you find some things that you didn't find when you're only looking at a small handful of people. But if we start skipping those small handfuls of people, those phase 1 and 2 and 3, and those phases of the trials, the drug studies, we're even giving up that portion of finding any kind of safety or efficacy issue with the drug. So I don't think we should be doing that.
And, you know, what I thought about was what Dr. Esselstyn told us about the HDL drug, the drug that was supposed to raise your HDLs. That's the good cholesterol. He talks about that and prevent and reverse heart disease. Are you familiar with that? What happened to that drug? Where
do you remember the name of it? Or?
I can't remember the name of it, but they got almost to going on market, and they had to call the CEO and say, we have a small problem. It's killing people in our trials.
I think I remember something about that,
Yeah.
and it was part of the brand new class of medications that are out there to try to raise the good cholesterol.
Yes, that's
and one of those in particular, they did find increased mortality rates.
Yeah.
I actually have an article on my website about HDL cholesterol, and I explain it all, and I explain some of the drugs that they use to try to increase HDL cholesterol. So if you want more in-depth information on there, you can just go on my website and find that.
Yeah. Okay, that'll be good, and we'll put that in the email. Judy, you have a question. Go ahead and ask it, and I'll say it in here. Can a person get too much B12?
I've never seen of a case of B12 overdose, and I think a big reason why is because the B vitamins, the B12 vitamin, is water soluble. So if you get too much, actually your liver is going to store enough to last you, I've seen anywhere between 2 and 3 years to 7 years worth of B12 that your body needs. Now, if you get more than what your liver can store, it's water soluble, so it's just going to be peed out in the kidneys are just going to excrete it in the urine. So I've never seen a case of B12 overdose and harming somebody.
I wanted to talk about something that Dustin's already covered. My father-in-law is 95 years old and doing very well, but he is on several drugs. And like Dustin said, he has 4 different doctors, a heart doctor, a primary care, a kidney doctor, and something else. And he gets some of his prescriptions mail order, he gets some at CVS, he gets some at Walgreens. And here about 2 years ago, he was having some problems. He was having problems with his memory. He wasn't himself. And so I took all of his drugs to a CVS pharmacist, and he almost passed out. he said he cannot be taking all of these drugs at the same time. There were some that he shouldn't be on at all if he was on this. There was some that if he's going to take this in the morning, he should take something else in the afternoon. It was really just a chocolate mess. And once we got it all straightened out and got his doctors online with what he had, he improved tremendously. So it is very important, if you're on more than one drug, make sure that all of your doctors, and all of his doctors are at the same clinic. You would think they would all know what he was on, but they don't pay attention. They only pay attention to what they're doing. So it is very important. I don't know what would have happened to him. This was 2 or 3 years ago, but he's 95 today and doing well. So do that if you're on several drugs.
I've actually seen patients come into the hospital and they'll be on 2 different statins at the same time. Wow. Because maybe their primary care doctor prescribed them Lipitor, and then they went to their cardiologist and he prescribed Crestor, but maybe the other didn't know the other was doing that, and then the patient doesn't understand that they're both statin drugs, so they just take them both.
Well, their computers are supposed to red flag those.
Yeah, but if you have a doctor over here on a computer system and a doctor over here on a different computer system,
But if they
they
go to
don't
the
know.
same pharmacy.
If they go to the same pharmacy. But sometimes, like Vicki said, yes, it's very important.
And so he should know that.
Yep.
But doctors don't know drugs the way pharmacists know drugs.
Yes, that's true. I wanted you to explain why people always comment about this type of lifestyle, that the animals give us the B12. How was that? I know, but I would like you to explain it. Thank you.
Well, the animals are the middleman, so it's like, you know, the animals eat the foliage and the plants that have the B12 on them, and the dirt that's on them with the bacteria, and then they get the B12, and then that's stored in their body, and then we eat the animals. We just kind of take it from the middleman and put it into us, but we also put into our body more cholesterol, more fat, and increase our risk of heart disease and diabetes and cancer and autoimmune diseases and all that good stuff too.
Mm-hmm. Yeah. Thanks for asking that, Karen. Yes, you have a question?
What test?
Well, you can actually...
Can you repeat that question?
Okay, so the question was, what test do you do to see if your B12 is correct or not? You can just do a vitamin B12 test. Your doctor can take your blood.
It's not part of the regular blood test.
Not normally. You usually have to ask your doctor to do a B12 level. Sometimes that will give you a good indication on whether or not you're deficient. Sometimes that misses the point, and there's another test called methylmalonic acid that is a little bit more rare of a test that they can do, and they can dig a little deeper and see if you're B12 deficient. So both of those tests.
You know, as I listen to this, I'm reminded again that what we're about is providing information, and you make those decisions about what you're going to do when you speak with your health provider. There's someone in our live stream, and they've talked with me about the body of research related to medications or related to diet. And you know, as I listen to all the experts that we've listened to, there seems to be a general feeling that eating your fruits and vegetables and your grains is good for you. You know, it just seems to be that they all agree with that. And then I'll hear a study that'll come out and it'll say, no, it's not good to eat that vegetable. And I'm thinking, well, that doesn't make sense. You know, it doesn't match the whole body of knowledge we've gotten. And I was wondering about that, if you had a comment on that. When we hear about the latest study that maybe says, no, coffee's good this time and coffee's not good that time, how does that relate to that body of knowledge that we know now about healthy eating? Should we react immediately to those individual studies, or?
No, I don't think so, because it takes really a broad range of data to really understand the whole story. And so we have to look at all that data over many, many, many years and see what has worked in general. And to your point where maybe there's a study that says, oh, you can't eat this vegetable now, or there's a problem with this particular fruit or something. That may be the case in some individuals' lives, because although fruits and vegetables and whole grains and legumes are healthy and good for you in the general population, maybe you're a patient that has, let's say, rheumatoid arthritis, and maybe one of the vegetables like the tomatoes is a trigger for you. So in that particular case, well, tomatoes are good vegetables. I mean, I eat tomatoes all the time. Most people can eat tomatoes and have no problem with them. But maybe for that particular individual, they'll notice that when they include tomato products in their diet, that their joints start to hurt and get inflamed the next day. So maybe they have to make exceptions to the rule in general on one particular food item or another. And that goes for migraine headache sufferers. There's certain foods, sometimes citrus can trigger migraine headaches. So some people might not be able to do that. Even though oranges and tangerines and the citrus fruit is normally good for you. So with every individual medical condition, there could be exceptions to the rule. And it's just important to not blacklist a certain product like citrus or tomatoes or whatever vegetable it is for everybody, because one particular study said that it's bad for one condition.
Well, Dustin, we really want to tell you how much we appreciate you coming. So, speaking of vegetables, we have something for you, and I think it's in there. You can just take the shirt off.
I'll give you this.
So, as a thank you from Chat and Chew, this kind of goes with the kind of theme that you were telling us.
Your key to success comes in the form of a grocery list and not a prescription. Thank you very much. I say that all the time.
This is by far the hardest song I've ever had to memorize, because so many people tell me, you forgot this, you forgot that, you need to add this, you need to add that. So just like many of you, probably I've watched television and noticed that there are so many ads for medication, as Dustin mentioned. Been watching TV and it bothers me. Most ads are about medications we should check. Few words of why they'll help us get by, then a huge list of side effects. I'm not a doc, but I do take stock. Listen closely, this stuff is suspect. They want our compliance, but this is not rocket science. These aren't just side, but whole body effects. Your muscles may ache, be stiffened or shake, may have tingling, tremors or hives. May be swollen all over, won't be rolling in clover, 'cause you will have lost your sex drive. Heart palpitations and hallucinations and sleep problems and seizures could occur. You may get drowsy and feel really lousy, and depression could happen for sure. May lose balance on occasion, oh, that constipation, skin rash and dry mouth expect. And you won't be needing all the internal bleeding. These aren't just side, but whole body effects. Your insides may rush, your face will be flush, may have chest pains and migraines, it's true. One other fear, you could have diarrhea, so your John will be flushed too. Backache and bellyache and headache and the shakes and nausea to varying degrees. May get dizzy and queasy and mighty uneasy, and that's why they call it dis-ease. Your speech may be slurred, your vision quite blurred, a hearing loss you may want to check. And it may provoke a blood clot or stroke. These aren't just side, but whole body effects. Where am I? Sometimes we're not patient, don't read all the information about the effects of the pills we just bought. We take it home and we read it, we're stuck, we can see it, spent big bucks for suicidal thoughts. I've taken time to reflect on all these effects, and I've studied all of them quite a lot. I'm seeking direction, 'cause here's the big question: are these things worse than the illness I've got? May cause infection or pain, a lot of weight gain, and abnormal thinking expect. Sore throat and sorrow so hard to swallow, these aren't just side but whole body effect. May cause shortness of breath, an occasional death. Whoa, that warning sure carries a sting. I'm not real crazy about pushing up daisies. I know death is not an occasional thing. Yes, some effects are scary. I'm especially wary when we have them. We're supposed to call our physician. But if I have an erection that lasts for 4 hours, I might as well call the mortician. Only take when you ate. Don't take with nitrates. Don't take with antidepressants. You may fall. If you reject having whole body effects, don't take this stuff at all. I guess I've conceded for some folks meds are needed. Bet how many do you think sure or not? What we read, what we hear, the research is clear. What we eat matters a lot. It's about habits, and it's about choices, and it's about time to begin. It's about learning and changing some habits, and it's all about self-discipline.